Now, if I'm really intent on reversing your work, and I just continually stuff myself, can I counteract the effects of the operation?
Remainder.
Yes, you definitely can.
So this is what we were saying before.
And that's why it's a lifetime, commitment, because you have to follow the guidelines that we provide and the diet that we give for the rest of your life. Because if in a couple of years you're doing great and then you change everything you're doing, you start eating more, in the beginning you're going to get sick, but with time it's going to stretch and you'll be able to eat whatever you want and potentially can reverse the positive effects that you had.
Now just very briefly, how long does this kind of surgery take, and what's the general recovery period?
The surgery takes about an hour to 2 hours, depending on how heavy you are and the anatomy that we see when we get in there. The recovery is usually in the hospital for 2 days. By the time you leave, you're up, you're walking around, you're doing pretty much everything you were doing before the surgery. You could have some aches and pains, but for the most part, you're okay.
Great.
And you mentioned this is laparoscopic or minimally invasive surgery, so there's no big scar. These are all sort of through the small ports that we're used to. Now we're used to seeing, but they're sort of still magic to me, because I remember the old days. But so is there a lot of skin pain, or is it more sort of the aches on the inside from the surgery you've done?
There is some skin pain, but actually the most pain is the gas, because when we go in, we have to insufflate and inflate your belly so we have room to work. Sometimes that gas takes a little while to get reabsorbed. Maybe you can
explain that to the patients. You're literally putting, use carbon dioxide?
Carbon dioxide. So when we put in one of those ports, we insufflate carbon dioxide in it, so your belly blows up. So now instead of everything being compact, we have room to work
and see
everything that we need to see.
Does it look like the picture that we saw there?
Kind of, not really.
It's all the same color, right?
If everything looked like that,
they don't have the stomach and the esophagus separate colors for you guys.
If everything looked like that, surgeries would be a lot quicker and easier.
So that's who do you do this gastric sleeve bypass for? How do you select this over the more well, it's not the gastric sleeve surgery. How do you select that over the bypass? And we'll talk about the bypass in a minute.
That's a more complex question. And a lot of it has to do with people's medical problems. It has to do with their eating behavior. It happens to do where they are in life and their risk profile. So it is extremely complex and only can be answered between the doctor and the patient.
So this is
an individual decision.
It is an individual decision, and it is personally something that must be thought about by both individuals and discussed on a one-on-one basis.
Well, maybe we could pull up the video for the second one, and then we'll sort of ask you guys to contrast them and just understand some of the considerations that go into make that. So here we are, same look from the outside.
Yeah, this is the gastric bypass, and once again, ports and instruments are used and through those small incisions. And the esophagus is
the anatomy's the same, huh?
Long tube connecting to the stomach. We got the same anatomy. And the first step is to use a stapler device to create a small stomach pouch that can only fit a couple of ounces of fluid in there. And then we staple the stomach, the small intestine, about 50 centimeters down.
So you actually cut the small intestine in half.
Divide it, and we bring that portion of the small intestine up to the stomach and sew the two together. And then we make one more attachment down below, as you'll see in a second. And what it does is it separates, it makes two pathways. One where the digestive juices travel, and the other one where there's the food travels.
So the
and where they meet is much further down.
Yeah.
And by bypassing the small intestine and most of the stomach, what happens is you lose weight, but it also has these metabolic effects. And I think where we used to think that the gastric bypass worked and helped metabolic effects such as diabetes and hypertension and high cholesterol was the bypass part. We thought that bypassing the pancreas and those organs there that make that digestive juice that breaks the food down, we thought that was the part that's important. But we're also finding that the sleeve gastrectomy does pretty much the same thing. And they cure diabetes similarly. And
so
it was an amazing discovery.
Effectiveness rate, is one better than the other, or one having better long-term effects?
We're finding there are several studies done that are showing that they are quite similar. So the amazing advance is that you can now do a much simpler surgery like the sleeve gastrectomy that Dr. Friedman was talking about and get similar results with diabetes. 80% cure rate. hypertension, high cholesterol, sleep apnea, all these medical problems improve. It's absolutely amazing to even us doing it every day.
It must be great to have even more than one tool kind of in your toolbox to really achieve similar ends.
Yes, it really is. You know, the surgeries have some different effects on people, what they can eat, side effects, and it's nice to, I always use the analogy of a shoe store. You go into a shoe store and the kind of shoe that I'm going to buy is very different than what you're going to buy. So it's good to have options.
And do you each specialize in one or the other of these, or do you both do both?
Well, I think we both have our preferences, don't we? But we're not going to say, all right?
Right. We do both.
We do both, yes.
And are these complicated operations from a surgical standpoint?
Well, I don't consider it very complicated because we're doing it every day. Mm-hmm. And I think we have gotten very good at this. When you do something every day and you know the nuances of it, it becomes a very straightforward operation.
And we've got about 30 seconds left, so you each have a chance for a final comment to the patients at home, to our viewers at home.
Well, what I can say is, coming from the patients I've taken care of, you know, we've seen patients lose a tremendous amount of weight, but what's really remarkable is the patients coming in with a bag of medication and then saying, "Doc, I don't take these meds anymore."
And their mortality is reduced substantially. We've run out of time. You'll get a last word during the question, Abe. So, but I want to thank you both for a wonderfully illuminating discussion. Really interesting, and it's sort of an amazing, new modern part of modern medicine. It really has changed the way we think about these diseases.
Here's this week's health question.
Hi, my name is Bill. My question is, what is a hiatal hernia?
Okay, Bill wants to know what a hiatal hernia is. We have two hiatal hernia experts on the set. Abe, what's a hiatal hernia?
Hiatal hernia is, if you remember the video that we had up, you have the esophagus connects to your stomach. So right above that connection, your diaphragm, where your lungs are, kind of covers it. And there's a little opening where the esophagus comes through, and that's where it meets the stomach. It's called the diaphragmatic hiatus. What happens in a hiatal hernia is that opening is big. So part of your stomach is up in your chest. You know, not in your abdomen, but part up in your chest. And when your stomach is up there, it could cause different things, mainly reflux, gastric reflux, because the pressure is different in your thoracic cavity and in your abdomen. So, you know, and they get quite big sometimes and could be difficult to treat.
So the esophagus actually passes through the diaphragm, which is like a membrane, and that helps keep food in the stomach and gastric acid in the stomach, right?
Normally.
Normally.
Right.
Correct.
But when you have the hiatal hernia, some of the stomach can come up, and that allows the reflux to happen more easily.
Yes.
Right.
And you can treat that with a pill. But
I was wondering if you as a surgeon would
But there's another way that Abe and I prefer to fix, and that's by bringing the stomach down, stitching or tightening up the diaphragm. And there's another procedure that we do where we take the part of the stomach and wrap it around the esophagus. It helps keep it there, but it also cures your reflux.
And that can be actually really important because we know chronic reflux can actually cause injury to the lining of the esophagus.
So it can be medically treated, surgically treated, and you've got to talk about that with your doctor. Sometimes they're even asymptomatic and they don't need treatment. Also, thank you both very much. We're running out of time. And if you have a question you'd like to ask us on Health Talk and get our experts or Andrew and me to answer, contact us at email@healthtalk@norhealth.org.
Thank you so much to our guests today, Dr. Neil Flock and Dr. Abe Friedman, for staying with us and telling us about metabolic weight loss surgery.
So we'll see you next week on Health Talk.